over Teams or whatever, and there was some, technical issues, which happens. So I'm gonna go over this and review a little bit from the first lecture. It'll be short, just some like the key takeaways that are the important points you guys need to know. So once again, Major Sandoval, emergency medicine PA. I went through IPAP in 2014. I was like a battalion or brigade PA, and then I did emergency medicine fellowship at BAMC. And then I was faculty for the Fort Hood program, the emergency medicine fellowship there, the assistant program director before I came here. So, all right. So let's get rolling. So some of like the key takeaways for our first lecture. Obviously, all the slides are important. Some of them were just kind of a review over like basic history, things like that. But like some of the key takeaways, obviously, what medications they need to take before the surgery and which ones we need to withhold. So one of the big ones that we like to talk about is like, holding the ACE inhibitor, just because it can cause refractory hypotension from that general anesthesia. So that's an important point there. And then anything like, a lot of times diuretics, we like to avoid just because the surgery is going to cause, likely going to cause some sort of hypovolemia, which is what we're going to talk about in the lecture right after this, and we're going to talk about fluid management. And then obviously any like anticoagulants are other ones we like to avoid before the surgery, because we're going to be cutting them open, they're going to be bleeding, so we obviously don't want them to bleed more. So those are like some of the common medications we like to discontinue before the surgery. Other important things to remember, all of the surgeries that we're cutting are going to get, 1 hour before the incision, they're going to get prophylactic antibiotics for like a surgical site infection to avoid it. So we typically like to use cefazolin. The other name we commonly use is Ancept because it's easier to pronounce, so you'll hear those two very commonly, and that's going to be just 1 hour pre-op before we do the incision, no more than 1 hour. And then based on the type of surgery, we may have to continue that antibiotic or add additional coverage for like anaerobes and things like that. And then, it's important you guys understand the ASA category. So, like, let's say you do need to know what sort of diseases fall in which category and what class they are. So, like, let's say we have, like a 50-year-old, he's got mild hypertension, he smokes a few packs of cigarettes per day, but otherwise is healthy. He's there for an elective surgery. What category would you guys think that falls under for ASA categories? What are we thinking? 2, right? So that's kind of similar to questions, we might ask you and things you need to know for this. Just kind of their comorbidities and what sort of surgery they're getting and what ASA category they fall in, okay? What if we had that same patient and they were insulin dependent diabetic, what would they be? Yeah, okay, good. And then obviously, like, hopefully you could hear me for this slide, but obviously we tell them to refrain from drinking any clear liquids, for at least 2 hours before the procedure, and then light meals 6 hours, and then fatty meals 8 hours before the surgery. So we usually tell them, that's usually the guidelines we give them prior to surgery day. And then this one, so what's important, the important thing we hear, obviously we do have to risk stratify everybody, especially if they have any sort of cardiac conditions or comorbidities. It's important. As long as they're not there for a cardiac surgery, it doesn't be like cardiothoracic surgery, not general surgery. So we like to risk stratify them based on what sort of conditions they have, and we kind of, there's calculators. Most of us use MD Calc. Once you guys get to phase 2, you're definitely going to need that. There's going to be a lot of calculators on there. Some of them you'll use so often, memorize them and it'll be easy. But for this, so let's say you have a patient, you're doing a pre-op physical on, they have like a history of some past like ischemic heart disease, and you have an abnormal EKG. What are you guys going to do at that point for your pre-op? Are you guys going to continue with the pre-op exam?
Stress test.
Or option, yeah. So you're going to refer them to like cardiology for a stress test at that point, so they can get cleared. Okay. So those are just important considerations when you're calculating these scores that you need to think about. And those that like I said, all of it is testable material. Those are like the more important ones that you should focus on, and you should know all the material. Somebody asked if the notes are testable. Yes, they are. Theoretically, everything in the textbook should be testable, but we put a lot of that into the slides, so we don't have to have you guys read up the whole textbook, because I know a lot of you aren't going to do that anyway. So the notes are definitely testable. And honestly, the questions are going to be a little bit more difficult than you're used to. The first test is always the hardest for you guys, just because it's a little bit of change of pace. They are similar to like how EMED asked the questions. I think you guys took that first test, right? They're similar in nature. That I reviewed the first test, or I was the previewer for it. So the questions are kind of similar. They're not going to be first order questions. They're going to be like third order. You're going to actually do some critical thinking. But I think you guys will all get through it. All right, let's talk about fluids. This one gets kind of in depth. So here's our objectives. We're going to go through, all the different types of fluids, the pathophysiology in the body, what the different compartments are, how we manage them, what sort of, arrangements we can have that can affect it. And all right, so I'm sure you probably remember back, what was it, freshman semester, you guys probably got a lot of this looking at our cellular fluids. So, the key takeaway here is, we're really looking at about a third of your body's water, or like a third of your body water, and then we're actually focusing down to an even smaller portion, which is really like a quarter of that is what we can really measure in the fluid and what we can affect and change. So 2/3 of that fluid is intercellular, and then the remaining third is extracellular. And as you can see on there, it kind of shows what the key cations are in those fluids and what we measure and how we can affect them. We'll talk about how this affects which ones are most important, like intercellular potassium, extracellular sodium, and based on the solute concentration, they kind of flow back and forth, which is why it's important. We need to recognize this, because when we have any sort of derangement to that, like if they lose some fluid, they have GI losses, or they have a surgery, we lose some blood. It's important that we manage all these. So it's very common after surgery that we see this, or even before it if it's some sort of trauma or bleeding related disorder. And then here's a better picture here. And what I want you to focus on is the bottom right there, when we have our blood capillary, and then we have our intercellular and our extracellular fluid. And this is really where we're making, where we're going to have the most effect, where we're going to manage most of this, and it kind of shows you the 1/3, 2/3 there. But this is based on, you have your hydrostatic pressure, which is like your pressure in a fire hose, or if you blow up a balloon. The hydrostatic pressure is the pressure that's inside of that balloon. And then we have, once you make it a semi-permeable membrane, like it is in the body, you're going to have fluid shifts across it based on the concentration of that solute, with the sodium and potassium. And that difference is going to be that's what's going to create your osmotic pressure. So it's important to realize this, because when we have these fluid shifts, especially with sodium, which we'll talk about the derangements we can have with that in a little bit, it's important we recognize where our fluids are, because then it can help us guide our treatment by figuring out, is it intercellular, extracellular, is it third spacing, and then it kind of guides our management down the road. It's not just as simple as let's just throw some normal saline or LR. We actually have to concentrate on what we're trying to fix inside of them. So, and how do we measure this? Really, we do it with osmolality, and we have osmolality and osmolarity. So we use them kind of interchangeably. One's based on body weight, and then the other is based on the amount of fluid, which is really what we measure. But we're going to use the terms kind of interchangeably. And then the tonicity is basically the extracellular solution that moves into and out of the cells. And that's going to be mainly sodium that we're going to be talking about today. And then, you're going to have hypotonic, which is your extracellular fluid has a lower osmolarity than inside the cell. So the net flow of water goes into the cell because of if you have a hypotonic solution. If it's isotonic, then they're the same. So you have no net movement. And then hypertonic, you have a higher osmolarity than inside the cell, so water will move out of the cell. This is important like a good example is like when we have a significant brain injury and we have swelling, one of the ways we fix that is by giving a hypertonic solution. So we give 3%, it's a 3% saline solution. So because of the high osmolarity, it pulls water from the brain out of the intercellular portion of the brain, and it reduces the swelling in there. So it's important we recognize all of these and understand them, because it can help us in managing our patient. And this one is a great example of, like, if you have a semi-permeable membrane, the higher solute concentration pulls water into it. So this is kind of how our extracellular and intercellular fluids work, and then the difference there is like our osmotic pressure. All right, and here's how it actually looks inside the body. So we have intercellularly, we have the potassium, which doesn't like to move extracellularly unless you have some sort of derangement, which we'll talk about, like hyperglycemia is a good one, or DKA. You'll sometimes see that potassium move from inside of the cell into the interstitium and plasma. But typically, sodium moves in between the interstitium and plasma freely, but water doesn't. So and then sodium usually doesn't cross that cell membrane. And why does it matter? Because hypovolemia is very common in surgery, especially, you're placing the body under a lot of stress. They're going to release catecholamines. And a lot of times they're going to have some sort of disease process that's going to affect this as well, like if they have a fever, if there's any sort of infection, especially if they're bleeding. This is going to, place a higher load on them. And so this just the surgery alone will stimulate aldosterone secretion, which leads to like a low volume of urine output. And this is something important we measure, and typically you lose about a liter of urine a day. I mean, I feel like I pee a lot more than that, but it's typically 0.5 mils per kg an hour. So, and we'll have some calculations later that we talk about. And then we got to think about our insensible losses that just naturally occur. So obviously our skin through sweating, we have our lungs with breathing, and then like it says on there, anything like a fever or illness is going to increase that. Now, if they have GI losses, like they have some sort of diarrheal illness or vomiting, this is going to play a big role in that. And what we have on the top there is like our fractional excretion of sodium, which is how we measure this when we're actually managing these patients, which we'll get into the calculations later. It's nothing you guys are going to have to calculate, but it's something that's calculated for you, and there's also calculators if you don't. If your lab doesn't actually do it, but most of the labs, almost all your labs will. All right, so the gold standard for this measurement for the sodium is typically a 24-hour urinary collection, which obviously is less than ideal. We don't have 24 hours to manage them when we're in the hospital, so one of the methods we use, or a better method, is our fractional excretion of sodium, like I just talked about. So it's a calculation, which you guys don't have to calculate it, but it's a lab that we're going to look at, and then that can kind of help guide us on where this disorder is coming from. So like it could be from some sort of pre-renal disease, which the pre-renal, if we don't manage it correctly, can lead to like an intrarenal or acute tubular necrosis. Or it can be post-renal. So based on these measurements, which we'll talk about shortly, this can help guide us, because one of the common derangements we see post-op is like hyponatremia. So, and we'll talk about what we do for all of those different disorders here shortly. But, and this is basically how it works. So if you have a low fractional excretion of sodium, it means like your renal reabsorption is going to be high, so it's going to retain those electrolytes. So it's going to have what we call like a high avidity, and we measure that in the urine with fractional excretion of sodium, and it's usually below 1%, so we know there's some sort of pre-renal disease or pre-renal process that's causing this response. Sometimes this can just be, you're something from the normal surgery, like we talked about in, this slide, just low volumes from oliguria or aldosterone secretion. Or, if this continues, it can go from pre-renal to an actual intrinsic renal disease like acute tubular necrosis or other kidney damage. So then it can progress to post-renal, in which when we're looking at how this moves through the body, it's basically your kidney has a low avidity at this point, because there's some sort of damage to it, so you're gonna spill larger molecules, like larger solutes, like your sodium, so it's gonna start to you're gonna start to waste it or pee it out. And this is something we measure, and it's important because this is gonna help us when we have like a hyponatremia, kind of identifying where it's coming from and what we can do for it, because based on this, it can lead to maybe they need more fluids or maybe they need less fluids and for just free water restriction, which we'll talk about shortly. All right, so like historically, we over-resuscitated these patients. So we always thought we need to give more fluids so we can avoid any sort of kidney injury. But we realized that we were causing a lot more harm than good with this. So now we try to use a little bit more precise measurements, which is not exact because we can't estimate certain losses to an exact science. Like we don't know how much they're losing on the skin if they're sweating. You know, if they're tachypnic, you might lose a little bit more. If they have some sort of GI process as well, you might be losing some. But we like to use a little bit more goal-directed or protocol-based, which we're going to talk about what our different maintenance fluid rates are, our resuscitative rates, and then our replacement rates as well. But one of the issues we see frequently is an acute kidney injury, which is typically like a creatinine over 2. And it's common post-op, and it's usually transient. And as long as we manage it appropriately with some sort of fluid resuscitation, we can avoid this, but it is common, and we will talk about managing it. And like I said, the most common cause of AKI is like acute tubular necrosis that we see, which is usually some sort of prerenal insult, which leads to an intrinsic injury, and most commonly is from hypovolemia, and we treat it, which is usually crystalloids as long as we're not suspecting any bleeding. All right. Well, let's talk about this fun algorithm. So we have there's 3 different pathways on here, and they all start with our assessment on the top. So we have our assessment. What are some signs we might see of like hypovolemia? Yeah, yep. So it's like objective findings. Yeah, low blood pressure. It might be tachycardic, tachypnic. The slide talks about the NEWS, which is the National Early Warning Score. So this is actually like, I think most of you or all of you will probably work with the new MHS Genesis. So like when a patient comes in, it calculates that, and it over calculates. It says like half your patients are in shock, but this is just like an early warning system for shock or some sort of derangement, which it actually says it on the chart and it like lights up, and you're like, oh, okay, just to help guide you, because when they're septic, we like to intervene early when we can. So you'll see that scoring system, but really it's just any sign of hypovolemia. And that kind of leads us down our algorithm. So if there is a sign of hypovolemia, then we move to the fluid resuscitation. Typically we start, it says 500, typically we start like a liter of crystalloids, followed by a second liter, and we check for a response. So that one's pretty easy, but what I want to point out is there's a difference between like maintenance fluids that you're going to give in the hospital versus resuscitation versus like a replacement rate fluids. And all of these have to be calculated to manage these patients. Like I was saying in the last slide, or a couple slides ago, that we used to, we typically overhydrated them, and we thought the more fluids, the better they are. But then that can lead to, secondary complications, especially with like fluid overload, pulmonary edema. I mean, there's all heart failure. There's all kinds of things we can cause if we over-resuscitate that patient, which is why we like to manage it. We like to thoroughly manage it and make sure we're using resuscitation versus replacement versus maintenance rates. So we've given those, our couple liters, they respond, so on our assessment, there's no signs of hypovolemia when we move down our chart here. And we can go to if they don't have any other sort of electrolyte replacement needs or any sort of underlying pathology, then we'll move into our routine just maintenance rate, which is 30 mils per kg. Over 24 hours, so you just divide it by 24, and we'll talk about that calculation in a few slides, but that's just our typical routine maintenance rate that really every patient gets when we have them in the hospital if they're NPO. So surgery, they're typically NPO. So we need to make sure we're giving them some sort of maintenance fluids because they're not able to drink any water or any electrolytes. So going down this chart, we also have to factor in any other conditions they might have, like are they dehydrated, Did they have vomiting, diarrhea before? Do they have any sort of signs of like sepsis, heart failure, any third spacing, so like gross edema? So that's when we have to factor in our replacement rate. And we have to add that to our normal routine maintenance rate so we can avoid going down that algorithm on the left side where we're resuscitating them. So it's, you know, it can sometimes be complicated, but it's usually pretty easy as long as we don't start out with them being hypovolemic. We can usually factor in what their replacement and maintenance needs are going to be. And we'll talk about that and what happens if we don't manage it here in a minute. But like I said, so we need to evaluate the hydration status. So are they tachycardic, hypotensive? And sometimes, you know, the body is really good at compensating, especially in kids. And then in the elderly, you're going to have comorbidities, or sometimes there are conditions that are going to blunt that effect. So they might be on the antihypertensive medication. So they're like a beta blocker, they might not have tachycardia when they're sick, which can be one of the earlier signs before they get hypotense. So another, if we suspect that, you know, let's say they don't have hypotension and they're like borderline tachycardia, like maybe they're at 90, sometimes we get an orthostatic blood pressure, and you guys know what that is when we do they do it laying down, sitting, standing, and then we look at differences in those, and typically it's over 20. You know, it's a sign of dehydration. So those are other, you know, indicators we can use if they're not, you know, if they don't present with like overt, you know, tachycardia and hypotension, tachypnea, and all those signs. You can also have dry mucous membranes, decreased skin sugar. If you get a UA, you know, your spec RAV may be elevated, and that can be a sign of dehydration as well. And this is when we would start, like we said, with those resuscitation fluids. Typically, you know, we give a liter, and then followed by another liter and check their response. All right, so how do we measure shock? We have our classifications here, and really, class 1 and 2 are kind of hard to differentiate sometimes. They may start to get tachycardic. They'll typically still have, you know, normal mentation. Typically not hypotensive yet. So what we're going to talk about really is class 3 and 4. And, you know, your patient will typically be a little bit anxious, confused. They might be agitated when you start to move into this. They should have, you know, or they will have hypotension at this point, and they'll be tachycardic. So this is when we tend to intervene, but the best way we can measure this, especially in the surgical patient, is with a Foley catheter, and we measure their urinary output. So if anything less than 0.5 mils per kg, then we need to start resuscitating them and giving them fluids to fix that. And typically it's our crystalloids, but if it's bleeding, then we get blood, which we'll talk about a lot more during block 3 in the trauma lectures. All right, so like I said, sometimes our vital signs don't reliably correlate to how hypovolemic they are. So historically, we used to use a pulmonary artery catheter called a Swan scan, which we'd have to float in. It was, you know, obviously it's invasive. It's going into the pulmonary artery. We don't use that typically anymore. I mean, there are rare instances in the ICU where like cardiology may use this, but you know what we found is that it has, you know, pretty significant increase in mortality, so we don't use it. Now we like to use ultrasound, which is a simple, you know, pretty reliable test we can do at the bedside. If you guys aren't familiar with it, you'll get familiar during your emergency medicine block. I know it's I think it's like block 4, or 3, 4, I think. One of your guys' blocks, or block 5 maybe. So you guys will learn like your EFAS exam, and then some of the other exams we can do at the bedside. But what we're looking for on these bedside exams, like we can look at our IVC, and we can measure it, or we can, I mean, a lot of times we can just look at it if you've measured a lot of them. And you can tell whether it's collapsing all the way, so they're dehydrated, or you can tell like whether it's plethoric, maybe they're you know, maybe we've over-resuscitated them. So that's a good bedside test we can use. We can also look at a bedside echo too, and just looking at their cardiac function as well, that kind of assess for hydration status. But those are easier and a lot less invasive and faster tests we have now, which you guys will learn here in the next coming few weeks. You guys will practice on each other. And then lab testing, like we talked about in the last one, you know, the pre-op labs are kind of tailored to what the procedure is, what condition they have, and nothing's really mandatory. Typically we do like to look at the CBC and the CMP before, and UA before everything. But post-op, we don't have to get labs. Like if it was just routine elective surgery, everything went well, we're not usually worried about that. Now, if they have comorbidities, if it was, you know, a lot more complicated procedure that we're doing, we'll typically have to monitor them post-op, and we'll have to monitor electrolytes, we'll have to look at urinary output, and, whoop, dropping stuff. And we'll just have to check all their fluid losses, and then for the critically ill patient that has any sort of like signs of hemorrhagic shock, we want to make sure we give them blood. So typically we'll push blood on any hemoglobin less than 7 in the emergent setting. And that's typically in the trauma patient. So what do we start with? Like I said initially, we start with some sort of, you know, warmed crystalloid solution, whether that's normal saline or lactated ringers. We typically prefer lactated ringers. Normal saline, and we'll look at the breakdown on the next slide of what, you know, what's in those, what sort of electrolytes are in those fluids, and why they can cause some of the derangements that they do. So if we give too much normal saline, we can cause a hyperchloremic metabolic acidosis, and hopefully you'll understand that in a second on the next slide when we explain it. But I mean, typically we have our our goal-directed or protocol-directed resuscitation. Like I said, typically we start with a leader as long as they don't have any comorbidities like heart failure, liver failure, or renal failure. And then we just reassess after a leader, and then we possibly give a second one if it's hemorrhage, once again, blood. So here's like our solute concentrations. And so as you can see, normal saline has, it's 154 saline or millicues. And then it's the same for chloride. The issue is we have like a strong ionic difference between these ions. So the plasma typically likes to sit at about, like what that value is typically like at 42. So basically you take all your positive ions and you subtract your negative ions, and that should be normal physiology should be 42. So as you see on the top, if you subtract, typically, your positive ions are your sodium and potassium, so if you subtract that, it's 0, which means you're going to be a little bit acidotic from that fluid, which is why it can cause a hyperthermic metabolic acidosis if we over-resuscitate them with that fluid. So to avoid that, we typically like to use LR in the emergent setting or trauma room, and then typically when they're admitted, Plasmolite is a really great solution that we use a lot more frequently on the inpatient side of the house. So, and as you can see, if you do your subtractions, it's closer to normal physiologic plasma, which is why we prefer those sorts of fluids. Alright, so like I said, your crystalloids for resuscitation, and for your maintenance fluids, we like to use like a D5 half NS, because they're NPO, so they're not taking in any sort of electrolytes or any other fluids, so we like to give them a little bit of sugar in there, and then it also has some electrolytes as well. And then, one of the issues we might have is if we have some GI losses, or if they have an NG tube in, we can lose some electrolytes, especially potassium. So sometimes we'll have to augment some potassium on there as well. We typically don't give it immediately after the surgery if they have any sort of hypokalemia, because sometimes that potassium can go from intercellular to extracellular. So sometimes just resuscitating them afterwards with that solution will push it back into the cells. So that's why we typically don't add it immediately, but hypokalemia is very commonly seen after surgery or post-surgery. So it is something we need to consider. And then and we'll get into it in a minute, but like hypokalemia, commonly magnesium is involved with intercellular transport of potassium through the cell. So that's why magnesium is an important one. And sometimes if we're giving them potassium and it's not increasing, we need to add magnesium to it in order to normalize everything. So they all kind of work together. All right, now on to our maintenance rates. This is basically anybody that we have NPO, they're going to be in the hospital. This is the calculation we like to use, is 30 mils per kg over 24 hours. So you just divide it by 24, and then that's our maintenance rate every hour that they're inpatient in the hospital. However, we also need to consider, like I said, that replacement rate. So do they have any fluid loss from anywhere else? Do we have an NG tube in? Did they have some sort of, diarrheal illness prior to this? Or any sort of comorbidities that can affect the displacement of fluid. We then need to factor that into our replacement rate, and we add it to the maintenance rate when we're managing these patients. All right. You got a 23-year-old female, presents to ED with nausea, vomiting, diarrhea, 48 hours, heart rate 145, blood pressure 85, tachypneic, but they're oxygenating well, GCS 14, pupils are, 3 millimeters, normal, reactive, cap refill greater than 2 seconds. What type of fluid prescription strategy are we going to use on this patient? What do you guys think? Yeah, resuscitation. Good. And I mean, as a PA student, you could probably argue like seek expert help is the right answer too, but no, right. So that one's kind of easy. All right, so now we're going to talk about like transfusions, like blood transfusion.
Sir,
So yep.
I'm sorry, can we go back to that question?
Yeah.
Why would it not be replacement?
So this patient is, they have hypotension, so the systolic 85, they're tachycardic at 145, tachypneic, basically every sign of hypovolemia is what we've given you on there, so that's going to be a resuscitation, right? You're going to have to resuscitate first. They'll eventually probably get a maintenance rate, but you have to resuscitate them before you move on to the maintenance rate. Basically, we have to stabilize them first. So this patient, we don't give you what's wrong with them, but what it looks like to me is sepsis. But likely they're just dehydrated from the nausea, vomiting, diarrhea. They could have some sort of gastroenteritis likely causing this, which we commonly see this. I think even norovirus, everybody's been warning about that going around.
Sorry, I'm sorry, I thought I said replacement, not maintenance.
Because like based on our algorithm on the other slide, like on your assessment, they're hypovolemic, they're dehydrated. So we need to resuscitate them first. Once we've resuscitated them and stabilized them, then we need to move on to what their ongoing fluid rate's going to be. So we'll have maintenance fluids if they are admitted to the hospital inpatient. The 23-year-old, we don't give any comorbidities, so likely healthy. Just usually resuscitating them will fix everything. Hopefully we can get them home. Now, if they were admitted, we would have to, once we resuscitated them, basically we normalize their blood pressure. They're not tachycardic anymore, not tachypneic. Their mentation's improved. Then we'll move on to just like a maintenance rate, and then we'll have to add like a replacement rate on what we think their losses are from that nausea, vomiting, diarrhea. And we can measure the vomiting. It's a lot harder to measure, the diarrhea. So we'll just, we kind of just rough estimate, and we reassess the patient, like I said, on their urinary output when they're inpatient for their maintenance and replacement rate. But this is definitely resuscitation. That make sense?
Thank you.
Yeah, I was just going to confirm that. So replacement doesn't mean like putting fluids back in the patient. It means like replacing their missing electrolytes on
Yes.
top of
Yeah, it's replacing the losses that we suspect are going to be added to it. Like we know that the normal maintenance rate is 30 mils per kg an hour, but this patient's got, severe vomiting and diarrhea. So now we're going to have to calculate, and we don't know the exact loss, but typically we estimate a lot of times 250 for GI losses, and we'll kind of add on to it. And then we'll just adjust based on the urinary output if we have a Foley catheter, or we'll do it on their vital signs and the patient's medication if we don't want to put a Foley catheter in there. All right, and then so for, obviously if we suspect hemorrhagic shock, we need to give them blood, not crystalloids, because like we kind of showed in the last slides, we can obviously worsen a coagulopathy, and then we're kind of diluting their blood as well, so we're worsening their acidosis, which can exacerbate that lethal triad there, which is why in the trauma patient we start with blood and not crystalloids typically. And then the latest guidelines we have, like in descending order on there, we have just our preferred blood types that we like to use, or blood products. So we most facilities now start with like low titer whole blood. You guys ever heard of like the walking blood bank? I know the medics and people like that should have probably heard of that. But so we've moved on to now just keeping cold storage, low titer, whole blood, because it's the most physiologically similar to your actual blood. When you know, you have all of your clotting factors in there, and I'll talk about in a sec the issue, but next in line, we use pre-screen low titer O fresh whole blood. That would be like your walking blood bank. We're immediately getting that blood off somebody else that's already been pre-screened. And then the third option there is what we call a balanced resuscitation. This was the standard for a long time, and it's still the standard in some facilities that you go to. And it's a 1:1 ratio of plasma, RBCs, and platelets. The issue is some of those take a long time. Some of those have to stay frozen until you use them. And the thawing process can take up to 20 minutes for some of them. So what we've found is that people aren't getting a balanced resuscitation. We were giving them a lot of PRBCs, but the other, like the plasma and platelets took longer, so we weren't able to get those as quickly, especially the platelets. So they weren't getting a balanced resuscitation until further into their resuscitation, like once they're, you know, in the OR, or they're admitted and we've controlled the hemorrhage, or we're trying to control it. They won't get all of those components till later on in the hospital stay, which is why we have kind of a lot of facilities that move to whole blood. And then next is plasma and RBCs, and then plasma or RBCs alone, if that's all we have. In some facilities, that's all you're gonna get. Sometimes even, you know, depending on if you're like in an austere environment, sometimes they might send RBCs out to you if you guys are having issues. Most of the time, we move to whole blood now, even in those situations. But obviously, we're gonna have a new battlefield, and that was the old one, so probably doesn't apply anymore. And that's kind of what we talked about. So like transfusion therapy, like we used to just use typically we used O-neg, packed RBCs, and we used, just because it takes a lot longer to type and cross blood for everybody's different blood type in an emergent situation. So we typically started with that, and then, you know, we move on to O-negative PRBCs we move on to O-positive if the O-neg is unavailable. And the issue with that is, like, sometimes, you know, if they're Rh negative in a woman of childbearing age, that can create some issues down the road. However, saving their life is, you know, arguably better than dying, so we will still give them that blood. They just may have issues once they decide to become pregnant. And then it's important to remember 1 unit of PRBCs raises your hemoglobin by 1 and your hematocrit by 3%. So that's something you guys should always remember. And then obviously we have on there all of the other different blood products we can give and why we do it. And most of it's for the clotting factors, but which is why we prefer whole blood, because it has all the clotting factors in it already. We don't have to thaw anything out. Here are some of the other fluids you might see. We used to use Xten, which is basically just like a sugar saline water type, or sugar kind of LR. But we actually found it was doing a lot more harm than good. It used to be in all of your medical equipment sets, like once you become PAs in a battalion, you guys would have this, and some of them still might, so if you see it, just throw it away. We don't use it anymore, but we just wanted to talk about it a little bit. And then some of your other ones, like I talked about hypertonic saline, so if you have those head injuries and brain swelling, we use the hypertonic saline to draw some of that fluid and decrease the swelling. And then the albumin, not usually used for acute resuscitation, but I've certainly used it for it, especially in those end-stage liver disease patients that have, like, obviously their body's obviously not compensating well because of the liver disease. So if you overload them with fluids, you're gonna cause a lot more problems like heart failure. It's also an issue if they have kidney disease as well. So we'll use this albumin because it'll expand the intravascular volume, and then we don't have to worry about pushing 3 liters, whereas I think the albumin, I want to say it was like 300 milliliters, but it's equivalent to, I don't remember the exact calculation, but it works a lot better in like our end-stage liver disease patients or liver failure patients, instead of just pushing a bunch of fluids if they're septic. And then here are some of the other fluids we may or may not use. Anybody use TXA in here? You guys, I'm sure you guys are trained on it, but TXA is a very common one we use. That's an antifibrinolytic. So, and then we also have, like, depending on if they have any sort of underlying disease, we might use cryoprecipitate or DEAVP. Which DDAVP is commonly used in surgery just because you might get persistent oozing, especially on long procedures in the operating room, so we may add some DDAVP on there. All right, so 75-year-old coming for a knee replacement, has hypertension, takes amlodipine, labs are all normal. You're gonna give some IV fluids. She's 80 kilograms. What do you guys think the rate's gonna be for maintenance fluids on her? What was that? Yeah. Number one, yeah. We like to keep the math very easy because for when I have to calculate it, so I like to plot a calculator. So yeah, it's gonna be number one. So it's just 30 megs, or 30 milliliters times 80 kg divided by 24. Everybody understand that for your maintenance fluid rate? Cool. Alright. So how do we measure all this? With the Foley catheters, the easiest way to measure this, it is a little bit invasive. Obviously, you're sticking a catheter, into the urethra and into the bladder. So it is a procedure we do under sterile conditions. A lot of times our nurses will do this procedure. I would, when you're PA students, I would try to get in there and ask if you do the procedure yourself and they can teach you. It's just something good to know. It's also something like I was deployed once and I was the only one who knew how to do the Foley catheter, being the PA, so I had to teach some of the medics how to do it. So that's another reason it's important you know the correct procedure to do this, because when you're downrange, it's gonna be like blindly in the blind if you don't know how to do it. You just count on your nurses to do it when you were in phase 2. So I would definitely learn how to do this. And then we kind of show the complications that you can have on there. So one of them is urethral injury, like the little frowny face. It means you didn't place it in far enough. It's still in the urethra and you blow up that balloon. If the patient's conscious, they're not going to be happy and they'll tell you. And then some of the complications, obviously you're placing, it's under sterile conditions, but obviously you do have, skin flora, you have bacteria that live just about everywhere. So you have to worry about a UTI. So a lot of times we'll get, urinalysis and urine culture to measure that. And then like I said, urethral injury, but the easiest way for us to measure their volume size is obviously with this. And then oliguria is definitely a good indication, like less than 0.5, that's a reliable sign of shock. All right, let's talk about electrolyte derangement. So we're going to start with sodium because it's the most common one post-op. And what we're looking at, it's not really, obviously a measure of your total body sodium, but it's just a measure, like I said, it's that little amount of fluid that we can measure is what we're looking at. There's a calculation on the next slide that you don't need to know about. We're just talking about it. But like your total body sodium is divided by your total body of water, and that's your serum sodium. And it's usually inversely related to your total body weight. But the most common derangement we see is hyponatremia post-op. So this is your sodium's less than 135. Usually it's just mild, so you'll have 130 or 134. Moderate's obviously in your 120s, and below 120 is severe. The problem with this is, especially when it's severe, it causes neurological, like CNS effects. So a lot of times you can have seizures and coma. Typically, you'll see a seizure first. If it's not your patient, you haven't been monitoring it, a lot of times they'll present with a seizure. They might have lethargy, and we'll talk about some of the other symptoms in a moment. But this is just a good indication of the water imbalance relative to sodium. And we'll talk about the complicated causes here in a sec. So, all right, what's important here is, I know this is a little complicated, but on like the little right or left-hand side, what you need to write on there is serum sodium, and then you need to write urine sodium, and then your serum osms, and then your urine osms. And this is how we're going to differentiate. And these are just lab tests we can do. This is mainly on the inpatient side when we're monitoring them, or post-op when they're in the hospital, not typically in the emergent setting. But this is what's going to help us decide what's causing this hyponatremia and how we can fix it. So if you kind of move on to the left side there, you're looking at your urine osms, and they're typically going to be 280 to 295, which is the normal range. This is going to be isotonic hyponatremia. This is typically caused from larger solutes, which in the blood, but they're going to be more solid, so you're almost going to get like a false sample when you look at the blood, because it's going to take a small sample and you're going to have this high concentration of these large solid particles, so it kind of throws you off, and that's why we call it isotonic hyponatremia, because it's really almost like a pseudo-hyponatremia. And this is usually from some sort of like hyperlipidemia, hyperproteinemia, but the more important one to focus on is that middle pathway there. So you drew your labs, they got a low sodium, so now we gotta get the serum osms, and that's usually less than 280, so that's a hypotonic hyponatremia, and then we need to look at their volume status. So are they hypovolemic? So if we move down the hypovolemic side, we then need to measure, we need to figure out what's causing it. Is this a renal problem, or is this some sort of extra renal volume loss, so GI losses, third spacing, could be from like sweating or oozing or burns on the skin. So these are, if your urine sodium is less than 10, then we have like a hypotonic hyponatremia, and we can differentiate their hypovolemic, so why, and then it's from GI losses. And the reason it's important here, like if it's over 20, it's important because some of these are things we can fix, like diuretics. If they were on a diuretic, we need them, they're obviously going to be spilling a lot more sodium because of the medications they're taking, and we need to discontinue them. And then obviously some sort of nephropathy is a very common one we see, so if they have any sort of chronic kidney disease, that's an important one. Maybe cerebral salt wasting rarely, but that's typically from like some sort of head injury or brain bleed. And it's kind of, we don't know the exact mechanism, but it's basically like central nervous system like imbalance that causes hyponatremia. And we kind of consider it as like a form of SIADH, but not really. So we move into our euvolemic category here. So this is when we need to look at our urine osm. So if they're euvolemic, we've got that low serum osms, and then we need to look at the urine osm. So if that's low, it could be from like a psychogenic polydipsia. So that's like, you'll see it in like schizophrenic patients. You'll also see it with a lot of those psychotropic medications we like to use as well. Lithium can cause SIADH as well, but lithium can also cause you to like excess thirst, so you're drinking a lot more water. But it does also affect the kidneys and can cause some kidney damage, which can fall into either of those categories. That's a common one you're going to see, like they're just basically drinking too much water, and that's why they're hyponatremic. And then the other one's like a low sodium diet. Have you guys ever heard of like perioperative? That's not familiar, no? That's something you might see. So, this can be from malnourished. And they're basically just taking in they're taking in some sort of fluids, like only water. With beer potomania, it's basically somebody who doesn't have an appropriate diet, so they're not taking in any other electrolytes, and they're just drinking a lot of beer. And this can lead to them peeing a lot, and so they lose a lot of that sodium. They're not replacing it with anything, and so they come in hyponatremic. And what's tricky about this, I had a patient, I don't know if this last summer, it was a while ago, it was like in the last year. The issue with hyponatremia is if it's severe, you come in usually in a seizure or coma. So he was seizing when he came in. He was a young dude. We were like, oh, what the heck? And we didn't know what was going on. So obviously we abort all seizure with benzos. So we gave him a bunch of benzos, aborted the seizure, and then he seized again. And we were like, what the hell is going on? So we had heard that he was like an alcoholic. So we were like, okay, this must be DTs. And obviously we treated him with more benzos. But once we got the labs back, we realized, oh crap, he's severely hyponatremic, and that's when it kind of cued us in, like, oh, maybe this isn't DTs, and he's still drinking. And once we actually controlled it, and we'll talk about how we do that here in the next few slides, we realized, yeah, it was beer potomania. So it's not super common, but I did, sometimes you do see it. It's kind of cool. So now, if you have your urine osms are over 100, they're usually over 300. This could be from SIADH. There are some hypothyroidism can sometimes cause this as well, or glucocorticoid deficiency, but not as commonly. Typically, you'll see SIADH, and then variable urine osms. We're not going to talk about the reset osma stuff. That is something to consider. Basically, your body's having a kind of normal response, but it has an elevation of your ADH, but you're basically, you still have the intact urinary secretion and normal water load. So it's just, sometimes we'll see it in pregnancy every once in a while. It's not very common though that we see that. And then our third category is like hypervolemic hypertension. So that's usually like your heart failure, cirrhotics, kidney disease patients. These are ones that are going to have they're going to be volume overloaded, but they're still hyponatremic. And these are the ones that are kind of tricky to, like I said, they have a very fickle volume status. So sometimes, our only options for these are we have to get them dialysis, or if the cirrhotics, there's a reason we call it end-stage liver disease, because we don't really have a cure, and you're probably going to die if you don't get a liver transplant. And then our third category over there is really if you have your high serum osmolality, and this is from hyperglycemia. So if it makes sense, like all of those solutes you have in your blood or your plasma, so hyperglycemia is another really large solute that's in there. So it can falsely change your sodium level. So there are actual correction methods we use. Usually it's a hypernatremia, but you can get a hyponatremia as well. It's basically just that solute's kind of crowding out because it's so big, the sodium in there, and you're going to get a false reading with it, like we kind of said on the left side there with those large particles. This is similar with hyperglycemia. You can get it from mannitol too, which is a medication we give, so it can be iatrogenic. We typically use that for head injuries. We'll talk about that in the trauma block though. All right, so what are the symptoms, signs and symptoms? Yeah, typically, if it's severe, you're gonna have that seizure, coma, you could have herniation, even death. So, it's important we catch this. Unfortunately, some people don't present until it's really bad. Like I said, they were seizing and, we figured out late. But you may have mild hyponatremia, which is when we can actually intervene early and help fix this. The key thing to remember about hypo and hypernatremia, we don't fix this quickly. Like, we don't fix any of these quickly because it's such, like the body has like such a fickle response. You will cause brain herniate, you can cause edema if you give it too quickly. You can cause demyelination, so we correct it like super slowly. These patients, they're going to be admitted. We typically fix it over like days, usually like 2 to 3 days or more to get them back to a normal physiologic range. But it is important that we identify this and we treat it early so we don't have to get to that severe hyponatremic component. But they may have nausea, malaise, headache, lethargy. What does that sound like? Every patient comes in, right? So that's why it can be kind of difficult to manage this, because like everybody comes in, I've just been feeling tired, I'm nauseous, and you're like, oh man. So, which is why it's on our our BMP and our CMP panel, and it's a common electrolyte we look at. But it is an important consideration post-op.
Sir, just a time check.
Oh, I started late, sorry. Yeah, you guys want to take a 10-minute break? Sorry. Who votes just let her figure it all out? You guys don't care. I'm just kidding. All right. All right, so moving back to this, we kind of, basically that algorithm we just had, we went through basically all of this. So you need to take careful history. What medications are they on? Are they on any diuretics, any psych meds, anything that can affect, anything that can cause that hyponatremia we need to consider. And then, obviously, like we talked about, any sort of changes in fluid or solute intake. And then the symptoms that may be associated with it that causes a high fluid output. And then we talk about how to, looking at the volume status and any signs of that, like, hypotension, tachycardia, stiff-neck, anything like that, decreased Ginzburger. All right. So what do we do for this? That's the ultimate question, right? Like I said, it's, we don't increase that rate very quickly. So symptomatic or severe hyponatremia, obviously, they typically require hospitalization. If it's symptomatic, very mild symptoms, and it's, they're in like the moderate to mild range, we may be able to, manage them just with treatment without having to call nephrology or anything like that. I certainly wouldn't call nephrology unless it's severe and you need some sort of specialist recommendation, like if they need dialysis or anything like that, you might call nephrology. But you need to monitor their fluid balance and weight very particularly. So this is typically going to be like an ICU patient versus just sitting on the floor getting checked on, every few hours or once or twice a day. But for severe hyponatremia, this is when they're going to have seizures. And as you can see on there, we only give 100 milliliters of 3% hypertonic saline, so it's not a lot, right? Like it's a very small amount, and it's usually over 10 minutes, and we don't want to correct it more than 4 to 6 in 24 hours, or else we can cause some of that, like brain edema, swelling. I mean, we can cause, not brain edema, we can basically, we're going to pull too much fluid from their brain, which can lead to like ischemia and even worsening. As soon as we can also cause demyelination from rapid correction. So those are all concerns we need to have. Which is why there's always a lot of arguments on this too, especially we've had in ICUs many times on how much we should give and how soon. And a lot of times it'll happen overnight when you have a lot less coverage on, and whatever provider doesn't understand this very well, they'll sometimes overcorrect it. And, thankfully the times it's happened to me, there were no significant, no bad outcomes, but it's something that you need to correct very slowly. All right, and like I said, how do we do it? Obviously, urine output, we make sure we got a Foley catheter, and then what sort of replacement they need. So sometimes, like in a post-op patient with hypernatremia, we don't have any of those other comorbidities. A lot of times we can just do free water restriction for them, and that's usually the quickest and easiest method we can do, and least invasive as well. And because we don't like to correct these things quickly, that's actually probably the most common thing we're gonna do is just free water restriction for them. Sometimes, we may give some saline on top of it or half normal saline, but typically free water restriction is our first option if it's not severe, they're not having any of those seizures or any of those significant symptoms. All right, moving on to hypernatremia. This is a lot less common. You don't see it very often. This is typically a sodium greater than 145. And then obviously they're gonna have a hyperosmolality because you have all of, that increased solute concentration. And then we just need to figure out whether it's renal versus non-renal, what the cause is. So when you have this increase in the high osmolality, it stimulates your thirst response and secretion of ADH, and it minimizes your urinary losses, so you're retaining a lot of that sodium. And so that's what typically leads to that hypernatremia, and then we just have to figure out what the cause is after that and how we're going to fix it. Same symptoms you have with hyponatremia, so you can, it's really those like CNS type symptoms. It can lead to seizures, coma, delirium. Fingers crossed I haven't ever had to treat a severe hypernatremia, and hopefully I don't. But typically we consider it severe when it's over 158. And then once again, we got to get their serum osms and kind of differentiate how bad it is. So, sometimes you'll have a patient with, I've had some with they were in I want to say it was 150 maybe, but they were completely asymptomatic, and the serum osms were normal. So something we, just managed. We didn't have to manage emergently. So it was somebody we just had to into the hospital and slowly correct it and find the cause. But like I said, you got to get that urine osms. They're usually elevated over 400. And then we have to figure out whether it's, non-renal versus renal. And a lot of that's going to be based on your history. Now, if your urine osms are low, then you're looking at some sort of diabetes insipidus cause, whether that's central versus nephrogenic. And like I said, lithium can also cause a hypernatremia and a hyponatremia, so it's always kind of tricky with lithium. Because once it causes it can cause issues in the brain, it can cause issues in the kidney, so lithium's just if they're taking it, you need to certainly get a good history and figure out what's going on with this patient. But it's not something that we see as commonly. And then we basically just need to replace the fluid. So one of the easiest ways, once again we don't rapidly correct, one of the easiest ways is just replacing water. So giving them water if they're able to tolerate PO. So it's usually it can be an easier treatment with these patients, but it is something we need to monitor and make sure it doesn't progress or they get any severe symptoms. But like I said, we don't correct it very quickly, and we typically start with oral water if we can. If they're euvolemic, that's great, and they're tolerating PO, give them water. And then sometimes we can give them a D5W with it will help. And then if they're volume overloaded, then sometimes we might just do the 5% dextrose. We may give them a loop diuretic to help with the natriuresis and lower the total body sodium. And then in severe cases, and if their kidney function isn't great or we have to correct it a little bit more quickly, and you have and you're at a dialysis center or a facility with dialysis, then a lot of times we'll go to hemodialysis for these. But here's our severe hypernatremia. So typically an isotonic solution to restore tissue perfusion, and we just calculate the free water deficit, which you don't need to know the calculation there, but we just look at their total body water, and then we do a calculation to get to their free water deficit, and we correct it. So, the goal is we typically get it below 140. And like I said, we don't do more than 10 per day with this correction. And same as the last slides, we want to measure the urinary output. And then we want to calculate what the water replacement is, whether we need to treat with bolus fluids versus whether we need to have diuretics. Are they still producing urine? Sometimes this can be from a kidney disorder as well. And let's get into one of the other derangements that we commonly see is hypokalemia, especially post-op. So this can be from like, if we have an NG tube in them, they could have, you know, gastrointestinal losses during the surgery because we're pulling out that fluid from the stomach, so we're going to lose some potassium as well. You can also get this from diuretics. That's why we have like potassium-sparing diuretics. And you might see it with malnutrition as well. So, and you typically have a prolonged alkalosis with it. And the symptoms you'll see are they're very vague. Most people are asymptomatic, but it can have decreased muscle contractility. And worst case, you know, if it gets too bad, it can lead to like paralysis, and especially if the diaphragm is bad. What we see this, so if we get a low potassium, we typically want to get an EKG to see if we have EKG changes on there, so you might have that flattener inverted wave. Then you'll get that U wave, which is the more common one we associate with this. What other condition might we see a U wave in? You guys remember? Like hypothermia, you might see it as well. But if untreated, it could lead to cardiac arrhythmias. So, and this one's easy to correct. We give them just IV potassium. We can also give oral potassium too, depending on how low it is and how quickly we want to correct it. So a lot of times, you know, I'll see it, typically they'll be like, you know, 5 points low, and we'll just give them some sort of oral supplementation before they leave the hospital, just to help put them in the, you know, within the normal limits. If you're given the potassium that's not correcting, then you need to make sure you're looking at their magnesium, which magnesium isn't part of like your CMP, so that's why a lot of times we forget it. We don't add it to our lab. So sometimes we'll order a mag and a phos on top of our labs is a common one we want to add to it. So if you're looking at like a hypokalemia, it's good to get your mag and phos as well with it. So you need to correct that hypomagnesemia in order for the potassium to actually transport back into the cells. And then hyperkalemia. So this is a bad one. This is an emergency. And this is something we commonly see in the emergency department, or that I see in the emergency department. And the issue is they don't really have any symptoms with it. So typically you really only see this with like your kidney failure patients, or most commonly see with your kidney failure patients. So it's something you need to think about. And the most common cause of hyperkalemia is pseudo-hyperkalemia. So it's actually a lab error. So like the specimen had clotted or hemolyzed, and it creates a false hyperkalemia. You guys will see this a lot in your clinics. You know, it'll be a young, healthy dude, and you drew the labs, but at the lab of your clinic, they send it to the hospital. It takes forever. So it's hemolyzed when it gets there, and they run the specimen. So everything else will be normal on there. One of the things you guys got to consider is, okay, what's going on with my patient? Oh, he's a 23-year-old male here for like a routine, whatever physical, special force physical or something that you drew these labs for. So likely they're, you know, probably not hyperkalemic. They don't have any sort of kidney disease or any other sort of comorbidities, but it is something you'll commonly see, and you'll probably send them to the ER, and we'll draw it again, and it'll be completely normal. So it's just something to think about. But for the emergent situations, a lot, when you have that elevated potassium, it leads to basically a deadly arrhythmia, and there's no signs and symptoms with it. So it's important we think about this, especially in that chronic kidney disease patient or anybody with renal insufficiency. We need to manage this quickly. So if that serum potassium comes back elevated, we need to immediately get an EKG. So if there's EKG findings, then that's an emergency and we have to treat it. So what do? The first thing we do with it is we give them calcium, typically like an amp of calcium. So this doesn't treat, it doesn't do anything for the potassium. All it does is stabilize the myocardium to help avoid those deadly arrhythmias. And the tricky part is the potassium number doesn't really correlate well with the EKG findings and the deadly arrhythmias. So this is why we kind of load the boat immediately when we see this. So, you know, some of the EKG findings you'll see initially is you get like a flattened P wave. You'll get that classic, you know, peaked T waves in all your leads. And then that can eventually lead to flattening and basically widening of your QRS and eventually death. if it's untreated. So first we give them that amp calcium, and then we need to figure out how to get the potassium back into the cells, which is why we give insulin, and then we obviously give them D50 on top of that, since we're giving a bunch of insulin and we're gonna tank their blood sugar. And then we typically give them like a continuous albuterol inhaler, which helps shift that potassium back into the cells. And then we can also add, if they're still producing urine, because most of these patients are in some sort of renal failure, so if they're still producing urine, we can give loop diuretics to help pee that out as well. There are some other ones you can give that are excreted in the stool, but that's, yeah, just a crappy situation. And we typically, your nurse says you should order that stuff. But that is another option too, like Kayexalase and Ovoisolin used to use, but we don't use it as much anymore, but it is still an option if you don't have anything else. And it's important to recognize this and treat immediately. All right. Which metabolic disorder is often associated with hypokalemia? What did we say? Yeah, alkalosis. And that's just because, like it says there, potassium ions are exchanged with the hydrogen ions in the kidney, so typically leads to that, to excretion, and then often you'll have that metabolic alkalosis. All right, and we'll cover some of the vascular access options we have. Obviously, does everybody know what like a peripheral IV is, or an IV catheter, typically 18 gauge. We're gonna do an IV lab, so you all get to practice on each other. Has everybody, who's all got an IV in here? All right, who's had to give one? Good, all right. Anybody like needle phobes or super scared of needles? Yeah. Yeah, sorry. Could be a bad day. All right, so some of the, typically that's in like the amputal file stuff, sometimes we do the forearm and the hand. Some of the terminology we use is like TKO is to just keep it open so it's dripping. Oh, sorry, my computer says it's gonna re-image. I need a re-imager, shut it down today, hang on. All right, so yeah, typically we call it TKO, an old way was KVO, it's just keeping it open so it's dripping, but we're not actually infusing them with anything. And then we usually put a heparin lock or a saline lock on there. There are like some older techniques like saphenous vein cut downs, which we're not gonna talk about, but then we'll talk about IOs as well. Who's had a given IO in here? Anybody? Yeah, nice. Yeah. So those are, that's something that we've pushed more as we, we progressed through like the war on terror, we started to give IOs a lot more just because they're easy. It's a lot easier in like your septic patient. Hold on, oh there it goes, okay. So yeah, there's our IOs, there's a couple options. So you got like the Fast One device, which looks pretty gnarly when you're looking at it. But you're basically placing a sternal IO, and then you also have your IO drills over there on the right, which is like your easy IO, which you can go in proximal humerus, which has the fastest rate, so typically in the proximal humerus. Then you got your proximal tib, distal tib, your sternum. You do your distal femur as well as one of the sites where you use it now. But your fastest rate is going to be with your proximal humerus when you're doing the IOs. So indications like if we can't get an IV, we tend to go to IO. So this, I've used the IO a lot more commonly, like in those infant population where it's hard to get an IV line. They're in extremis and we need to get something quickly. So a lot of times we don't use the drill, but you just use hand pressure and kind of screw it in, and it's pretty quick and easy to use. I know it sounds vicious, but sometimes it's the only line we can get. And you can push any of your resuscitation medications and fluids through it. But like I had said, the fluid rate it's kind of site dependent and patient dependent, so you don't get as fast of a rate when you're using an IO. And then obviously contraindications, you don't want to place it in any fractured bones. And then our central line, so this is a common one we get in like our critically ill patients, especially with like our trauma patients and resuscitation, when we need to push a large amount of fluid in that patient. So you're just using basically a very large bore, and you're able to push fluids a lot faster. I think we can push a unit of blood in like under a minute when we have a central line, versus like, I don't know the time frame for peripheral, but it's a lot longer than that. So a lot of those patients will get a central line on them. And we'll show you the technique here in a second, but we can do a lot with it. We can even give parenteral nutrition through it. And then we also have a lot of cytotoxic medications that you can't push through a peripheral IV, so that'll require a central line. Like some of our pressors that we use will require a central line. And then you can also run like a transvenous pacemaker as well through it. You can do temporary dialysis through it, but typically we use a dialysis catheter, which is like a garden hose basically, is the only way I can put it. It's huge. It's big and scary looking. So that's typically your dialysis catheters. But you can do dialysis if need be. They have a pretty high complication rate. So a lot of times we do like a subclavian, which is up here, and you're running, under your clavicle, and so you have, a pretty high chance of hitting a puncture in a lung. So that's a common complication from it. And then another one is, since a lot of times the artery is running next to the vein, sometimes you can get an arterial cannulation, and then you obviously got to worry about a site infection as well. We're doing this a lot of times in the emergent setting, so it's not as sterile as we'd like it, so you'll see a lot of catheter-related infections with this as well. All right, and there are some of the different locations we can use, like the subclavian and the internal jugular, the more common ones we use now. The femoral is the fastest, but we have a lot of like infection complications with it. And there's usually a higher rate of cannulating the artery as well when we do a femoral, but it is the fastest, so sometimes we will go to that in the emergency room, and we'll usually take it out once they get to the OR and replace it with typically a subclavian or an internal jugular. Internal jugulars becoming a lot more prevalent now, just because it's very easy to visualize with your ultrasound machine. So a lot of times we'll just do an ultrasound IJ, as long as it's not an extremely emergent situation, so you'll see that very commonly. And then we rarely do it in like the EJ or cephalic veins, it doesn't work as well. The technique we use is called the Seldinger technique. So you're basically putting a needle into the vein, and then you're threading a wire through the needle. You pull the needle out, and then you basically have to make an incision where your wire is to open the skin up, and then you're just placing this really large catheter in there and threading it over the wire. And as you can see, like in the picture where it leads, like you're almost into the heart. So that's why with whatever technique you're using, typically IJ or subclavian are the most common that you're going to use. So you can have some, quite a bit of complications, but it's definitely very commonly done. About, hopefully you guys get to do it in phase 2. You guys know where you're going yet? Okay. Yeah, so unless it's a trauma center, you're probably not doing this. And the other reason is because if it's not a trauma center and you are doing it, there's usually a fight because they don't do it often, and who's going to do it, and you're usually the low man on the totem pole, unfortunately. Hate to say it, especially if there's a residency there, you're probably not going to, but if you're a trauma center, you'll most likely do this. Is anybody going to BAMC? No. It's probably a good thing. Then we have our PICC line. So this is like a peripheral IV, but it's extremely long. So it's going to go threaded all the way to the SVC. So basically, it's like your IV, like in your normal AC, but it goes all the way up. And typically you typically have a PICC team in your hospital that places these. This isn't something you guys place. So it requires, some extra training. So typically there will be a PICC team, which is usually consists of nurses. And you'll call them and they'll come down and put this PICC line in. And like it says, like you avoid, the pneumothorax complication, but you still have all your normal complications like infection, the catheter could break, and air embolus. And then our ART line. So this is for pressure monitoring. We commonly use this in like conditions we need to get. We need to get exact measurements on their blood pressure. So like your head injuries are a very common one. We'll start an ART line in. Typically we use a radial ART line. We do femoral as well. I've never done an axillary or heard anyone do an axillary, but I guess you can do it there too. And basically this is just going into the artery is the difference on this one. So instead of the vein, you're putting in the artery and you're measuring, it hooks to your monitor and it tells you their exact blood arterial pressure. So for those conditions that we need to know, we need exact measurements. That's what we use these for. We don't push any fluids through these. And then you got your implantable ports, like for your chemo patients, or people who are on like long-term antibiotics. They'll have these ports, and they'll usually tell you when you treat the patient. They'll say, "Oh yeah, I have a port." We typically There are protocols on whether you should use the port or not, so you always have to think about that before you use this port if you can't get in a peripheral IV. All right. And then, like we kind of talked about IV rehydration, we talked about our maintenance, our resuscitative, and our replacement rates. So typically, if we have a patient MPO, we like to give them some sort of rehydration to meet their normal metabolic needs. And we can use this for up to a week. If they're going to have a long hospital stay, then we need to think about how we're going to give them nutrition, and we'll talk about those different the different methods we use for that in the next slide. So we have our gastric tube. So this is like an NG tube or an OG tube we place. It's not typically, we don't like to typically use it for any sort of nutrition. This is typically just to relieve pressure in the stomach. We need to remove any fluids. We don't want them aspirating when we're doing surgery. So a lot of times we'll place some sort of gastric tube, whether it's NG or OG. And then, like it shows on there, the contraindications, obviously, if their face looks like that, you probably shouldn't stick an NG tube in through their nostril. So any sort of facial trauma, we want to avoid that. And then, yeah, there's obviously complications, everything like we talked about. You lose a lot of potassium when you're in the stomach, so when you're drawing a lot of fluid out there, so you always got to consider replacing that in a metabolic alkalosis. Then we have our short-term feeding tubes, which is, we call it a Dopphoff tube. It basically goes post-pyloric. It has, it's radio opaque, so you can actually see where it is. It's pretty easily placed. There's even machines now, so we don't have to get x-rays or anything. We will get an x-ray afterwards, but there are some machines we can use as well that basically it's just looking at the metal, and it doesn't give you any visualization, but a lot of times the nurses place these for you. This is for short-term feedings. It can be like 6 to 8 weeks. Obviously, contraindications, if they don't have any intestinal function, you probably don't want to give them this. If there's any sort of like post-op stasis or ileus, bowel obstructions. But this is definitely an option we have, and you'll see it a lot of in inpatient settings for feeding. Then we have our actual feeding tubes. This is for longer term. So this is basically, we're placing a tube through their abdomen, and it's going somewhere in their small intestine, whether that's the PEG tube, or whether, so like a PEG tube, which is a gastrostomy versus a jejunostomy. So it's just, they're both similar, it's just different placement, and these are better for longer term feedings. You will treat patients that actually have these at home, so this is something that you'll definitely see in like your younger pediatric populations that are malnourished, and they probably have some sort of like neuro disorder on top of it. You'll sometimes see these patients, and a lot of times it's because their tube fell out, or because they're a toddler, they pull it out. So a lot of times they'll follow up, or they'll see you, hey, pull the tube out, what do I do? And typically, we're not gonna get into it, but there are methods and time frames you use to replace that tube versus giving a new one. But this is a better option for your longer term feeding. And then here are the different, basically the indications that we use, like enteral nutrition. So like we said, if there's a long-term hospital stay, they're PO intolerant, a lot of times we'll want to use like a PEG or a J tube. And then there are like the contraindications, like we said, obviously, if they don't, they have a bowel obstruction, they like intestinal stasis, ischemia, we don't want to give it. And then we can do total parenteral nutrition, so we can give this through their IV line. It's going to be only through a central line though. So this is basically anybody who has those conditions we were talking about where they can't get an enteral feeding will then go to TPN. And typically this is, longer hospital stays, like comorbid patients that are very complicated is when we tend to use this. And also, we also have to worry about malnourishment too, like in a refeeding syndrome. And it's important to recognize that that we can get our like MAG and FOS, because hypophosphatemia is a common complication with the refeeding syndrome in those malnourished patients. So if you administer a bunch of, glucose during periods of starvation, the electrolytes are shifted to maintain adequate serum concentration. So when you're giving these feedings, a lot of times you're removing all of those you're moving everything back intracellularly, and it can cause a refeeding syndrome and lead to death. So we've managed these very carefully when we have these patients. All right, we got 64-year-old male, develops a supraventricular arrhythmia after undergoing open heart surgery, potassium 6.7. After administering calcium, what is the next step? Insulin and glucose. Good. Good. Now, if they're, if they have CKD and they're on dialysis, then dialysis is going to be the ultimate answer. But acutely, the only thing we can do is insulin and glucose. And that top answer is one I was telling you that we don't use often anymore. It's a poopy day if you get that. So that causes like severe diarrhea, and your nurses will hate you. All right, and there's a patient with all the tubes in place, with an ICP monitor on top of it. So that's going to be a really sick patient there. All right. So there's everything we covered today. I know it was a lot. What questions do you guys have for me? No, gotta have some. All right. And then for my clean core group, whenever y'all are done, I'll be in my office. I gave my number. Whenever y'all want to start, we'll be in 2207. So if you finish early, just let me know. If not, we'll do it at 1500 down there, okay? All right, and I'll stick around for a second if y'all got any questions you want to come up and ask about.
I wonder if you'll get to that section.